So, starting the session, this is not a training course, but a question and answer session for our registered candidates who are undergoing different online server-based courses. So this is a pure question and answer session. This is not the course they are already taking from the server, and today we will take the questions from our registered candidates. So, first question from Dr. Padma: what is the significance of the uterine artery notch? Second question from Dr. Prajakta: how to measure the liver in transverse and in superior, inferior? Next question from the same Dr. Prajakta is that how to take a diameter. Then Dr. Anshu, how to differentiate an IUGR, whether this is symmetrical or asymmetrical depending on the charts. And the last question from the Dr. Nidhi is that how to differentiate rpocs from an AV malformation. So I have concluded these questions. These are the copy-paste questions which we got. So we will take these questions. So, question number 1, first question: how to take a diameter? Anybody? If I'm having that candidate, whosoever has posted this question, I will now interact with that candidate, and if she or he is not available, anybody can raise the hand so that we can discuss one-to-one. So this is the beauty of the interactive sessions. If anybody is not even online during the interactive sessions, we can take the question and we will send the recording of the discussion. So anyone, please raise your hand. Yeah, Dr. Milan, we are sending you a new invitation. Please accept it and say hello. Hurry up, Dr. Milan. Say hello. Quickly, Dr. Milan, say hello. We are sending you a good invitation. Dr. Rahim Khan also. Dr. Rahim Khan and Dr. Milan, say hello. Say hello if you are able to hear me. Oh, your voice is cracking. Next. Dr. Milan, say hello last time. Wait, I will send you an invitation. You have to accept that invitation. And on accepting, you have to say hello. So, with me is Dr. Nidhi. Dr. Nidhi, you are registered with us, yes or no?
Yes, sir. I'm registered with you.
So, which course you are taking?
Sir, I'm taking basic ultrasound.
Basic ultrasound. Okay. Tell me how to take the volume. First of all, what I should take when I am taking the volume of anything. Forget about ultrasound. What are the measurements?
We have to take all the 3 dimensions: length, breadth, and the depth.
Okay, hold on. Very good. Length, width, and depth. Now, there are 3 points which we have to take: length, width, and depth. Now, tell me, in ultrasound, in which section I can take length? Longitudinal or transverse?
The longitudinal.
Longitudinal. Depth, I can take in transverse or in longitudinal section?
So in transverse as well as in longitudinal.
Very good. Now, the width. Width can be taken in longitudinal or in transverse?
Transverse.
What is the moral of story now? If I have to take 3 measurements for volume, what I have to do? I have to take 2 dimensions. By two dimensions, I mean I have to take transverse as well as longitudinal section. Am I right or wrong?
Right, sir.
It means, now this is the point, it means that whenever I am taking volume, I have to take two sections, one of transverse and one for the longitudinal section, right or wrong?
Right, sir.
That is why we are having dual image mode in your machine. That dual image is not to save the paper, but one of the application is that we can take volume. Give me the pen. Now, whenever I am taking a dual image, on one side, I will be keeping transverse, and on other side, I will be keeping the longitudinal plane. Right?
Right.
Now, this is the monitor over here. On monitor, I am having here transverse section, and here I am having longitudinal section. So I will be taking two planes. Coming? No, it is not coming. Hold on. Now I will show you whiteboard. The things will be more clear on whiteboard. Now, in longitudinal section, now see, in longitudinal section, I can take a length. Dr. Nidhi, what else I can take in longitudinal section?
So depth.
Depth. What about transverse section?
So, in it, we can take the width.
Width. Very good. Does it mean, now see, does it mean that depth can be taken only and only in longitudinal section? Yes or no, Dr. Nidhi?
Yes.
Yes or no?
Yes.
No.
Yes.
Depth can be taken here also. Now see, depth can be taken in transverse also. So depth can be taken in transverse as well as in longitudinal section. The only thing what I have to see is the width. Width cannot be taken in transverse section, longitudinal section. And length cannot be taken in transverse section. Clear up to now? Yes or no? Dr. Nidhi, say yes or no? Am I audible to you? Probably voice got disconnected, but the point here is that in transverse section and in longitudinal section, I can take length here. Now you write it down. This is already discussed in the physics and machine settings course. So because the question has been raised, that is why I have to elaborate this now. Longitudinal section length and depth. Depth can be taken here also. And here we can take width. Now, putting all length, depth, and width together will give you volume. This is the point. So, for volume, I need two sections where I will be taking the appropriate measurements. In only transverse or in only longitudinal section, I cannot take volume. So there is the button in your machine, which is by the volume only. Once you will press onto the volume, it will ask for measurements, and it will ask for 3 measurements. You have to give 3 measurements. Then only volume will come. And That is why when you are taking a PCOD and OVD, and maybe that you are not giving the appropriate measurements, your PCOD is overdiagnosed or missed. So you have to take all sections. By all sections, I mean both sections, and you have to take all appropriate measurements. What I will request you to go back to the physics and machine settings. There is a complete class on the screen orientation, and there is one more class of volume. The volume class only is of 30 minutes. So I will request that candidate to go to the physics and machine settings, and please revise that. Maybe that candidate has not yet taken a class. Okay, next question. What was the next question? Next question, yes. Next question was that if we are having this discordancy in the uterine artery, what does that mean? See, in uterine artery, whenever I am taking the uterine artery, I have to see for whether there is a persist. That is completely discussed. That is a complete topic in the fetal color Doppler. If that candidate has not yet taken this color Doppler, I will request that candidate to go through the topic, which is the color Doppler. It is very much detailed over here. Now, if I am taking the right uterine artery, and right uterine artery is showing me high resistive index. What is high resistive index? That is the part and parcel of fetal color Doppler. That will take about 2 days. So we are taking here just question and answer session. That candidate will understand my answer, but whosoever has not taken our course may not understand. Now, if, for example, the right uterine artery is showing me persistence of the diastolic notch or a high resistive index, now you will understand what I mean by high resistive index. But if there is no diastolic notch and there is a sufficient diastolic flow, which means that I am having a good diastolic flow in left uterine artery. Now, the question was, what does this mean? And how to interpret this? Now, keep this thing in your mind. So this means that there is discordancy between right and left. What does this mean? Now, we have to see the uterus as a whole first. If placenta is on the left side, if placenta is on the left side, left lateral placenta, this is left side, not on the right side. And whenever I am taking this side, uterine artery, which side? Left one, where I will expect more of the diastolic flow. Where I will expect more of the diastolic flow? In left or in right? If placenta is on the left side, I will expect more flow over here in this uterine artery than this uterine artery. So the point is, it depends on where the placenta is. If placenta is on the right side and I am having a high diastolic flow on right side, but a low, comparatively low diastolic flow on other side, I will not worry much, because it depends on the placenta. If placenta is on the same side, I will expect some more diastolic flow on that side. But if placenta is fundal, then I will not expect any discordancy. I will not expect any discordancy, and any discordancy there should raise an alarm. So to conclude the question is that we have to see the placenta, and accordingly we have to see which uterine artery is showing me discordancy. But in funnel, I should not have any discordancy. So what was the next question? Yes.
Actually, I have a question.
Just hold on. We are not taking now questions. We are already done with the questions. We have taken a list of questions. If we will be left behind with the time, we will allow you to take give you a question. So the next question is how to measure size of a liver in transverse and in superior inferior. It simply means that how to take a measurement of liver. Stop. This way. No. Yeah. Now, whenever you are having a liver, again, what is important over here is that transverse and longitudinal sections. Please go to the physics and machine settings class and clear the concept of transverse and longitudinal section. So in transverse section, yes, how the liver will look like in transverse section, like this. Now I have to take measurement from here till here. This will be transverse section. This is transverse section, and this is the anterior posterior measurement. So AP means anterior posterior, that can be taken in transverse section. But what about longitudinal section? How the liver will look like in longitudinal section? Like this, in length, and I will be having kidney also, right kidney. So whenever I am having a right kidney in length, whatever liver is seen is automatically in longitudinal section. So here I have to take measurement from superior, inferior. Why is superior, why is inferior? That is already discussed in the server-based course. It means that I have to put probe like this, just below the subcostal, and I have to angle it towards the liver, and I will be seeing liver like this. Whenever liver is like this, this is in transverse section. Then I have to rotate the probe, not here, I have to slide it. Now see, I don't only have to rotate it, I have to slide it this way towards the kidney, so that kidney will come now on screen. Whenever the kidney is coming on screen, automatically liver is cutted in longitudinal section. So this way I will be taking the longitudinal section. So there is one more question. So what was that question? That is why I am copy pasting and I am showing these questions in beginning so that we will not miss any question. Yes, growth charts, IUGR and asymmetrical IUGR. So how to differentiate? The question from Dr. Anusha. If Dr. Anusha is online, please raise your hand. Or any gynecologist, please raise your hand. Let us discuss IUGR, symmetrical and asymmetrical IUGRs. Dr. Nidhi again raising the hand. Dr. Milan, Dr. Rahim Khan. We are sending you unmute invitations. Dr. Mamta, Dr. Padma, whosoever will receive the unmute invitation, please check your background noise. There should be no background noise. Say hello.
Hello, sir.
Yeah, what is your name?
Nidhi.
Dr. Nidhi. You are a gynecologist?
Yes, sir.
Yeah, Dr. Nidhi, I will discuss with Dr. Nidhi. Others, please mute your microphone. Otherwise, there will be a lot of background noise. Except Dr. Nidhi, everybody, please mute your microphones. Dr. Milan, there is a lot of noise from your side. I am muting you. Dr. Rahim also. Dr. Nidhi?
Yes, sir.
Yeah. Dr. Nidhi. Dr. Nidhi.
Audible, sir?
Yeah, audible. Now tell me, in brief, this is a question and answer session. We are not discussing it in detail. Which course you are taking, Dr. Nidhi? Are you taking any course right now? Yes or no?
Sir, I'm registered with you, sir.
You are registered. That is what I am asking. Which course you are registered for?
Sir, I'm basic ultrasound and basic gynecology obs.
Very good. Now, being a gynecologist, let us draw a fetus over here. Please bear with my drawing. I am having a horrible drawing, but purpose will be solved. Now, this is the head. In symmetrical IUGR, now see, in symmetrical IUGR, head circumference and abdominal circumference both will be decreased, yes or no? Dr. Nidhi, should I repeat?
Yes, sir.
Symmetrical IUGR. Can you see the whiteboard?
Yes, sir. Both will be decreased.
Wait, is my whiteboard seen? Yeah,
Yes,
symmetrical. Now see, I am talking of symmetrical IUGR. Both HC and AC will be decreased. Yes or no?
Yes.
What does this mean? This means that HC AC ratio, whatever machine is giving you in chart, will be normal or abnormal.
Normal.
Very good. It means that whenever machine is giving you HC-AC ratio as normal, you are then dealing with a symmetrical IUGR. Yes or no?
It can be symmetrical IUGR. Sir.
That is what I am saying. You may be dealing with symmetrical IUGR. There are a lot of many things, but we are right now differentiating asymmetrical and symmetrical laws only. But in case of an asymmetrical IUGR, what will be decreased more, HC or AC?
The AC.
AC. So AC will be dropped in case of asymmetrical IUGR. What will you expect this HC-AC ratio now? Normal or abnormal?
Abnormal.
Abnormal. Very good. So in one line, whenever HC-AC ratio is normal, you are not dealing with asymmetrical IUGR, but you are dealing now with symmetrical IUGR. Of course, we have to differentiate a lot of things over here. Maybe that the fetus is constitutionally small. These things are already discussed in color Doppler, fetal color Doppler. Yes, very much detailed is in fetal color Doppler, these topics. So this way, you can broadly differentiate between symmetrical and asymmetrical idea. Dr. You stay with me. Don't mute your line. Now, the last question which I got is that how to differentiate whether I am dealing with AV malformation or rpocs.
So that is my question, sir.
That is your question. Oh, very good. Now, you know the answer. My job is to prove that you are knowing, but you actually don't know that you are knowing this. Got confused with the statement? I'm repeating. I will prove that you are knowing, but you don't know that you are knowing this. And I bet.
Okay.
Dr. Nidhi.
Yes, sir.
rpocs.
Yes, sir.
rpocs are in endometrial or in myometrium.
So in the endometrium.
Endometrium. Now, in one line, you will get the answer, your answer. But AV malformations are in myometrium or endometrium.
Sir, in both, sir.
Why both?
It might connect endometrium with the myometrium.
But it will be also in myometrium, yes or no?
Yes, sir. Yes.
But rpocs will never go into the myometrium. Yes or no?
Yes, sir.
Now, if you know the basic thing, you know this. Now implement ultrasound on your statement, whatever you are knowing. What do you think? How ultrasound will prove this?
So, we will identify the endomyometrial junction first.
Next.
So next, we will put the color.
Very good. Color. Now, if you will put a color box, where you will expect more color in case of rpocs?
So in the endometrium only.
Hold on. Where you will expect more flow in case of AV malformation?
Sir, in both the regions.
In myo also.
Myo also.
Now, I conclude. You are knowing the things, but you are not able to interpret this. Yes or no?
Yes,
now let me elaborate. That is what I told you. You are knowing the things, but I will prove that you are knowing this, but you don't know that you are knowing this. Now coming to the detailed discussion of this this UA malformations. What is this UA malformations? This is actually, what will be the clinical presentations? Clinical presentations will be severe, can be severe, life-threatening, massive bleeding in young women. Yes or no?
Yes.
Yes. Now, what is the pathology?
So abnormal arteriovenous connections.
Yes, abnormal, without any intervening capillaries. Yes or no?
Yes.
So they are classified as congenital and acquired. Now coming to the acquired, which are more commonly seen. What are the causes of acquired AV malformations? Tell me.
Repeated DNCs.
Repeated DNCs. Okay, next.
Sir, uterine infections with retained products of conception.
Done. Third, multiple pregnancies also. Now note it down. Multiple pregnancies also. Previous section. This cesarean section also. Yes, cesarean section also. Termination of pregnancy. DNCs. Now coming to our ultrasound. How ultrasound will show me. Now this is the uterus. Now see, this is the uterus. This is the endometrial cavity. Now what in case of a retained product? Retained product will be somewhere in the endometrial cavity. But the point is, Only and only grayscale will not make any diagnosis of rpocs, and it will not differentiate a blood clot from an rpoc, right or wrong, Dr. Neri?
Sorry, sir. Sorry, sir.
Without color Doppler, I am repeating, without color Doppler, you cannot differentiate whether I am dealing with a blood clot or rpoc, yes or no?
Yes.
Yes, good. So it means that I will be seeing a hyperechoic mixed ecotexture lesion in endometrial cavity. But to make a diagnosis of rpocs or a simple blood clot, I need a clot. I need a color Doppler, CD color Doppler. Now, if I am putting a color Doppler on this hyperechoic lesion, in case of rpocs, will it show color? Yes or no?
Yes.
Yes. Now, in case of a blood clot, will it show color?
No.
No. So that way, I can differentiate whether first I am dealing with an rpoc or a blood clot. So I am taking your question in great detail. Now I know that I am dealing with an rpoc. Now let us take rpoc. In case of rpoc, you will be seeing flow around this lesion, yes or no?
Yes, sir. Inside.
Yes. Yes. If it is rpoc, now see, if it is rpoc, but in case of AV malformation, I will write in short AVM. Where will you expect these AV malformations? In endometrium or more in myometrium?
More in myometrium.
More in myometrium. So the point is, you will be having flow in myometrium, more in myometrium that can extend up to the endometrium. Right?
Okay.
Now, if you don't have a color Doppler, will these vessels look like some tubular structures on grayscale? Yes. But on the basis of grayscale only, you cannot make a diagnosis. But grayscale should make you to think that I haven't had to put a Doppler. Because maybe that you will be seeing some anechoic tubular areas in the myometrium that will make you to think maybe I am dealing with an AV malformation. Then put color and they should show you color if it is AV malformation. Clear?
Yes.
Now, let me try to get a patient of rpocs if I can get. Just hold on. So this is the patient where we are putting probe just above the pubis symphysis, and we are saying this is the fundus of the uterus, and this way is the cervix. And actually, this probe has been rotated anti-clockwise. Now that is why this is a mirror image. Anyhow, this is the endometrial cavity, and this endometrial cavity is having this area of mixed ecotexture. Can you appreciate this?
Yes, I can see, sir.
Now see how on a real patient it is looking like. Now see, this is the real patient. You come here, you will not see this much of clarity. Either you will be seeing this thing, or you will be seeing this thing, or you will be seeing the control pattern. Now this is the beauty of demonstration, online demonstration. Now see, I have seen this mixed ecotexture area over here. Can this be AV malformation? Now see, the myometrium, it looks clear over here. and I am having a clear RPOC in the endometrial cavity.
Yes, sir.
How I can differentiate now whether I am dealing with an RPOC or a blood clot? Let us discuss RPOC and blood clot over here. Putting in color, yes?
Yes.
Now, on the basis of grayscale only, I cannot say whether this is a blood clot or RPOC. So now, setting the machine, what I have to do with the settings that is discussed in physics and machine settings video. So, anyhow, measuring this like this. So this is about a 3 centimeters. So not a small lesion over there, a big lesion over there, which can be a blood clot or an RPOC. Now I will make use of color Doppler over here. I will put a color Doppler over here to see whether it is taking flow or not. Now this is the transverse sweep. In transverse sweep also, this is coming over here. This is in transverse sweep. Now putting the color on this lesion. Adjusting the color box. Adjusting the PRF. Again, how much to decrease and increase, what to decrease, that is again a part and parcel of physics and machine settings. Anyhow, this is the box over here, and I am now seeing the flow over here. Flow over here. So now see, if it is RPOC, it should take the color. So now, if I will take a flow, I mean the pulse flow, Dr. Nidhi.
Yes, sir.
If I will take a pulse flow from these vessels, which are now confirming that this is an RPOC, will you expect a high resistive index in this or low resistive index?
The low resistance.
Very good. So as a second confirmation, I will see. Now see, first of all, the visual impression on color Doppler. It is showing color, color, color. Now see the color. So this is first confirming me that I am not dealing with a blood clot, but this is a RPOC over here. Then if I will be putting a gate over there, and it should show me a high diastolic flow. So that is already discussed with you. What is it mean by the low resistive index and high resistive index? So this way, I will be seeing an RPOC. But if I am having an AV malformation, first of all, may not show me an RPOC. I am using over may not show me an RPOC. And these vessels will be more in the myometrium than in the endo. Okay, so this way we are differentiating between the RPOC and blood clot, and next between the RPOC and AV malformation. Anything else? So with this, we conclude today's session. This was just a question and answer session for our registered candidates who are taking the different courses from our website. So thank you very much, all of you. God bless all of you. So you will be getting an update of our this next session of this question and answer session. You have to post the questions in your WhatsApp group, in your batch WhatsApp group. Don't post it on mail. So you are added already in the WhatsApp group. So post it there on our helpline number, which is 4 times 9 34 72 42. You have to post your questions there only. So then we will take your questions for discussion. And this is the number where you have to send your questions. Not always you will be sending the questions, but whenever we will ask you to pose your question, that can be on alternate basis, that can be on after 2 days. So this is the helpline number where you have to send, but you have to keep an eye on your this WhatsApp batch group. You will get an update there. with a request that you can post your questions, and once you will post your questions on this helpline number, we will be taking your questions for interaction and for your detailed answer. Thank you very much.